everyone, and welcome. We're going to give one more minute for the 100 and so odd people that wanted to spend the evening with us to get logged in, and we'll get started. Do let us know where you're joining us from. I think Dr. J and Dr. Joy would, if I get that straight tonight, I'm going to get a star. I think Dr. J and Dr. Joy would love to know if we've got any preemie parents in the audience. And but we'll get started in just a second. Grab your cup of coffee and hey to Las Vegas, to Virginia, Detroit, and we'll get started. Oh, wonderful. Thank you guys for joining us this evening. So excited for this conversation with two of my favorite people. And by the time we are finished, they will be yours. Tonight's micro lesson is before the due date, changing the story on premature birth. And some of you may be surprised that while we can't always control whether mama delivers early, there are some things that we can do to perhaps mitigate the likelihood in some cases. So, a few stats: 1 in 10 babies in the US are born too early. And for Black birthing families, that is even a higher risk. I won't say the number because I think that's going to be a question for Dr. Joy. I am joined tonight by Dr. Joy Baker. Dr. Baker is a brilliant obstetrician. She's a board certified obstetrician, Morehouse School of Medicine alumna. She's a former faculty member of Morehouse. She's a physician known for pairing medical excellence with a deep compassion. She also has an incredible heart for this work and for Black mamas overall. But she is particularly, something that she shared with me recently is that her goal is to close the racial and social gaps in care. And that is her life's mission, which I find amazing. And then also, one of the people who was one of our founding members, our founding faculty for Birthing the Magic is Dr. Janet Williams. Dr. J, as we affectionately call her, is a doctoral prepared certified nurse midwife. She is founder and CEO of Transitions Women's Health and Consulting. She's a fierce advocate for equity. She is an author of at least two books, right, Dr. J? And she has over 2 decades of experience supporting families, training clinicians, and providing culturally responsive midwifery care. But I always say that my babble of an introduction is never enough to highlight the work that our brilliant faculty do. And so as we go through this, I'm going to ask both Dr. Joy and Dr. J to introduce themselves. As in terms of housekeeping for tonight, we don't have a formal presentation. We're going to have a conversation, and you are invited to actively participate. We'll talk about what we think you want to know, but then there may be some things that won't come up for us or have not come to mind for us that you want to share. And so drop it in the chat, drop it in the Q&A, and we'll get started. But before we do that, Dr. Joy, would you do a better introduction of all the brilliant things that you're doing?
Well, I think that your introduction was lovely and very kind. My name is Joy Baker. I am an OBGYN practicing in rural Georgia, which is why I look like this because I still have people laboring right now. Don't worry, we have coverage for them for the next hour. But I really enjoy this work. I've been in practice for about 15 years. As Marie shared, I went to Morehouse School of Medicine and trained there for my residency as well, and have been working in underserved areas now for the bulk of my career. So I'm very happy to be here with you guys, and I just love anything that Marie and Birthing the Magic puts together. And so I try to make as many of these as I can. So I'm very grateful to be here tonight.
Thank you, Dr. Joy. And can I do a tiny brag, Dr. Joy, and announce that Dr. Joy has joined our board of directors? So we haven't done our official press release yet. That'll come out tomorrow, but y'all are the first to know. Dr. J, would you introduce yourself?
Sure. My name is Dr. Janet Williams. I'm a doctorally prepared certified nurse midwife. I've been a midwife for 23 years. I left clinical practice 2 years ago, but I worked in a municipal hospital system in a large midwifery practice for those years, and I took care of a wonderful population of Black and brown women, a lot of Black and brown women, and we spoke over 100 languages at this hospital through interpreter services. So I've worked out in the community. And what has gotten to me is that I know that women and families need to have education. They need to know what's going on with their care, with their bodies. And that I found out there are so many things out in the community that we don't even know about that are there to help. So I am retired now, but I have a consulting business where I still go out and speak to the medical community, and also to families and community services, to make sure that people still understand and learn what they need to know and know what's available to help them through this situations of pregnancy and women's health. And I get to work with dynamite people like Dr. Joyce and Marie. So this is great.
Thank you, Dr. J. And speaking of what we often hear, but maybe we don't fully understand, is premature birth. Would you mind to provide for us a consumer-friendly definition of premature birth? Well, how is it defined? Um, why does gestational age matter so much? What do I mean by gestational age? That sort of thing.
Okay. So I'll just start with premature labor is when the body starts to prepare for birth too early. And that's before 37 weeks is completed in pregnancy. So a full-term baby is between 37 and 40 weeks. So anything before the 37th week is considered premature or preterm. And that's when the preterm labor can be when the uterus starts to contract and the cervix may start to open or thin out before the baby's fully ready for life outside of the womb. It's important to know that this doesn't always mean that birth's going to happen right away, but sometimes, they get some symptoms, and with early recognition and timely care, labor can sometimes be stopped or delayed long enough for the baby to keep growing and developing. Most pregnancies, though, progress normally and result in healthy full-term births. But being aware of what preterm labor means can help families start to recognize the changes sooner and get support they need. The goal is not to create fear tonight, it's to create awareness. And the more that people understand what's happening in their bodies, the more likely they are to speak up and, communicate, because that could make all the difference, improving outcomes.
Thank you, Dr. J. And something that you said prompted a thought for me. Dr. Joy, when Dr. J says what's happening in their bodies, can we talk a little bit about what is happening in mama's body between weeks, say, 28 and 37? What's happening and why is it sort of important for us to understand? Oh, you're muted, Dr. Joy. Or it doesn't say that you're muted, but we can't hear you. I think your microphone may not be.
Oh no.
Oh, now we can hear you. There you are.
Okay, I was like, what is going on? Okay, so, but essentially, that's the time in which you're in your third trimester of pregnancy. And generally, we like to think of that time, I like to call it the feed and grow period, because many times all of the baby's organs and body parts have already formed by that point. And then the baby is just growing and sort of maturing its organ systems and getting ready to live outside of the mom's body. And so anything that occurs that actually can start the labor process early is something that we get very concerned about. Like Dr. J talked about uterine contractions happening before the term period between 37 weeks and 40 weeks. But then also there are a host of other issues that can occur during that period. For instance, preeclampsia, which is where women develop high blood pressure and they start losing protein in their urine. If that occurs, sometimes that requires delivery, during the preterm period. Also, uncontrolled diabetes. I just admitted someone a couple of hours ago who had really uncontrolled blood sugars and needed to be delivered before 37 weeks. So there are a myriad of issues that can occur where not only are we just having premature uterine contractions, but maybe we're having medical issues that make it more dangerous to keep the baby inside versus delivering the baby earlier and monitoring that baby outside of the mom. So there are so many issues at play when we talk about preterm birth and why it occurs. And we certainly know that, like many other um, issues that women may face during pregnancy, that Black women and babies are disproportionately affected by preterm birth. So I'm really glad that we're having this very timely discussion just after World Prematurity Day. On Monday.
Thank you, Dr. Joy. And see, I was making a quick note because something I did not know, despite hanging out with you guys and thinking I know a lot, is that uncontrolled diabetes can lead to premature birth. That's a learning for me. When we talk about premature birth, sometimes when you're in the hospital, they'll say it's a late term preemie or a late preterm birth, or it's a moderate preterm birth or an early preterm birth. What do those phrases mean for us as birthing parents or grandparents? Um, Dr. Joy?
So when we think about like the degree of prematurity, that's really gonna depend on the gestational age. And the gestational age just basically means how many weeks pregnant are you? How long has this baby been in the oven, so to speak? So we really kind of rely on the gestational age to sort of set expectations for for that baby's ability to survive outside of the mom's womb. So we think probably somewhere between 22 and 24 weeks is the earliest that babies are able to survive outside of their moms. So babies who are born in that very early period can really, really struggle because they may not have full lung development yet. Their heart is not the muscles in the heart may not be fully mature, so it may be difficult. They may have, abnormal heart rates or rhythms. They may not have a fully matured gut. So it may be very difficult for them to eat and absorb nutrients. And so there are just a variety of problems that can happen for those babies that are born before 28 weeks. They really are some of the highest risk. And so those are our micro preemies. Those are, the really, really tiny 1 pounders, 2 pounders. That are born, and essentially those babies need every aspect of supportive care, from supportive oxygen. Many times they have to have a tiny breathing tube put down to help them breathe. They may need a feeding tube to help them eat. They need incubators to keep them warm because they don't have enough body weight to actually maintain their own body temperature outside of their mom. So micro preemies, those before 28 weeks, are probably those infants who unfortunately often succumb to death before they're 28 days old. And so we really get concerned about those micro preemies. And then you have your folks who are maybe 28 to 32, some people say 34 weeks. And those are sort of your premature babies or infants, and then those who are 32 to 34 weeks and above are considered your late preterm. So from 32 to 37 weeks. 32 weeks is the point at which we think most babies actually can survive pretty well outside of their moms. They often will behave more like 37 weekers versus those micro preemies who really need a lot of support. The 32 and above week babies may need some support, but are usually able to fend for themselves enough to survive.
Mm. Thank you for that. I know personally that can be a little confusing. Um,
Hmm.
and sometimes for parents, when you think about the images that you see for that for preemie babies, that probably tends to be those 22, 23 weekers with all the tubing, and it's just scary. So understanding that there are some fairly distinct differences in their level of care and survival rates, right? Um, so now that we've talked about the definition of what preterm birth is, right? Can we talk about what some of our families like what they feel? What are some of the signs and symptoms for mom that says, I need to call? So, Dr. J, what are some signals that you wish expectant parents recognized earlier about their bodies and their pregnancies? Um,
What I first want to say is that preterm labor comes very quietly most of the time, and people are not sure what they're feeling at that time. People don't feel like what they would imagine labor to feel like. It's very
mhm,
subtle kind of changes, often a very dull, persistent backache that doesn't go away, mild abdominal tightening that comes and goes, but more than 4 times in an hour, they're feeling it. Um, Feeling of pressure down low in the pelvis. Some may notice a difference in their vaginal discharge during that time, or sometime a little bit of spotting or trickle of fluid, maybe even. They might have broken their water. And like I said, it can start so softly. And so I tell families, if you feel something different, even if you can't tell me what exactly is feeling different, something is not right. Something feels different. I tell them, don't wait, call. It's always better to reach out and get checked than to sit home at home and wonder, is everything okay? I'd rather them come in, get checked to make sure everything is fine and it's nothing. And if they notice tightening, spotting, leaking, anything like that, the first thing I tell them to do is try to hydrate. Stop what they're doing and pay attention. Hydrate, drink some water. We see a lot of premature, I'll call it contractions, like during the summer when it's hot and people get dehydrated. They didn't drink enough water, they're perspiring. Sometimes just drinking water can stop those early preterm kind of contractions. So I tell them to make sure they hydrate and but call your provider, make sure that you are in touch and I'd rather you be over cautious than under cautious. It's called being proactive. So that's the main thing that I want them to report is that pressure that they're feeling, contractions that are coming and going, if a change in their discharge, anything like that, to call and get checked.
And I
thank you.
think those are great tips for people to have. And I will say that just as Dr. J shared, preterm labor sometimes can be really insidious.
Mm-hmm.
And a lot of the symptoms that we just heard also can be related to normal third trimester pregnancy. So
Exactly.
it is very important to have a good relationship with your OB care team and feel like you can speak up and ask questions
Yes.
because there are testing that are out there for preterm labor that we can actually do. We can monitor to see if you're having contractions. There are swabs that we can do that look for a specific protein that is present when people have may be experiencing preterm birth. Although I will say it's kind of a strange test. It's called a fetal fibronectin, and I'll type that in the chat for people who want to learn more about that. But it looks for a protein that's released during labor. However, this protein can also be around if you recently had intercourse or if
Mm-hmm.
you were bleeding. And so this is a vaginal swab that's used, but oftentimes we will not do that swab if you recently had sexual intercourse or you had bleeding because it can make it falsely positive. But there are things that are being developed to help us detect who might be in preterm labor, or if your water is broken, there are also testing that we can do for that too as well. So it is important to go ahead and reach out. If you are seeing something change, it's important to say something so that you can at least get uh, get on someone's high alert list so they know that yes, this person is experiencing changes. Maybe I didn't detect anything today, but maybe in 2 or 3 days, there may be something different. So you just want to have it on your radar and have it on your physician or midwife's radar.
You make a brilliant, and thank you for that, Dr. Joy and Dr. J. So we talked about the signs and symptoms, and so and it's a little scary that they're not as obvious. My water is not necessarily going to break, but if you and I love knowing that there are some tests that the practitioner can do. They run the test, and it does look as if I am starting preterm labor. Is there something you can do to slow it down, stop it? What happens next?
Well, Dr. J made a great point about hydration. Believe it or not, being dehydrated actually causes the uterus to contract. The uterus is made out of smooth muscle. And so when you get dehydrated, those muscles will just begin to contract. So hydration is first. And so oftentimes we will have the person, drink. I try to get my ladies to drink at least half a gallon of water a day or sugar-free drinks with electrolytes. So we really need to hydrate. Sometimes we give IV hydration, but there are also medications that are specific for stopping preterm birth. There's somewhat of a controversy in the medical field, however, about using some of these medicines. For instance, some people may have experienced preterm contractions and been given a shot that was supposed to stop those contractions. That's a shot called terbutaline. And terbutaline, while it is very effective at stopping contractions, for, a few minutes to a few hours. It also has some pretty gnarly side effects that we want to be very careful of. So it should really only be used in dire situations when we really need, to delay the contractions for a while. There have been some other medications that have been studied, like Procardia, which is a blood pressure medication. It has been known to help stop uterine contractions. And then we, have some medication drips. Magnesium sulfate is one that we use not necessarily to stop contractions, although people have used it in the past for that purpose, but we use it to help promote the baby's brain maturity in the event that we think this is an imminent preterm birth, like this baby is coming, we need to do something to help. So we can use that. But really, I always say labor is a moving train and it can be very difficult to stop it. And so sometimes we just have to brace and prepare ourselves for a delivery. I recently had a 28-weeker that I had to deliver at my facility, and we are not a NICU. We don't have a neonatologist, which is a special pediatrician that sees those really, really tiny babies. So I had to call in a team of people from 50 miles away to be present before I started. This was a person who was having a cesarean delivery, but she was not stable enough to transfer. So I had to call the neonatologist to me. So sometimes all we can do is just brace for it and hope we have all of the right supports for that mom and her premature infant.
Wow. That sounds like a series from Grey's Anatomy,
I know, right?
right?
That sounds
You,
so different to
I
me.
definitely think we need a
Right,
reality
especially.
show at my office for sure.
Oh, that
That
sounds
what you're saying sounds so different from where I worked, and we had the NICU right around the corner. So the fact that you have to bring someone in 50 miles, yeah, that is definitely a whole different type of practice.
something I can we stop for a moment? And I know this sounds maybe a little attention deficit, but when we talk about NICUs and we talk about neonatologists and then there was something recently where people were talking about levels in NICUs. Can we help our audience in case there's someone who may not know what that means? Um, Explain what the NICU is and how that may differ and who is a neonatologist and why that teen came in for your 20 what was it, 27 weeker, 28 weeker?
Sure. So there are definitely levels. So there are levels of infant care and there are levels of maternal care now. So at one time we only had levels of neonatal care. So you can have level one, two, or three NICU. And that kind of just denotes what age of babies that facility can take care of. So we are a level two NICU, so we do 32 weeks and up. for that. So and then you have a let me not get this confused because the maternal levels go the opposite direction. So we really could do well to kind of combine these levels, but um, let's see, somebody correct me if I'm wrong, but I think your level your level one is your highest level, and then your level three is your lowest level for babies. But for moms, it's opposite. So, the higher the level for moms, the higher the level of care. For babies, the lower the level. I think I'm saying that right. Am I getting it wrong?
You're saying it wrong. It's
Okay.
reversed.
Okay.
The
What do
higher,
you
the
do?
higher, the higher the number, the higher the acuity. So a level 4 NICU is the one that's going to do ECMO and
Oh,
have
okay.
the
Okay. Okay.
bells
So,
and
so
whistles.
yes, I'm messing
So
that
are
up
they the
again.
same? Yeah, yeah.
Well,
Sorry
but
to put you. That's fine.
no, that's good. That's good. But I just, plus I've been up for like really long time right now, so I might be talking gibberish. But I think that, it is important to understand that. And that is a very valid question to ask when you come into a center and you know that you are less than 37 weeks pregnant. What level of care is available for my baby? And it is very reasonable to to ask to be transferred to another facility if you are indeed stable enough to transfer. And by stable enough, I mean the baby is not, just a few minutes away from being born, or the baby has a normal heart rate on the fetal heart rate monitor. Um, or mom is in a stable condition. So sometimes moms may have issues that are happening, really severe blood pressures, things that would keep us from being able to load you safely into an ambulance and have you travel a distance to get to a higher level of care. And so that's what happened with my 28 weeker is that I could not safely transfer them. So I had to call someone to help us here at this center.
It's brilliant. We feel smarter already, don't we, my friends? Speaking of smarter, Dr. Joy, you did say you were talking about the tests that can be run that you don't do if I've been sexually active and recently, or if I'm bleeding. What is the protein that needs to be detected?
It's called fetal fibronectin. I dropped it in the
Oh,
chat in
that's what you
case
put in the
somebody
chat.
just
Okay.
wanted to
Yeah.
um,
Okay, I
look
see that.
more into it. But that is it, and that is a test that is used for its negative predictive value. And what I mean by that is that we know that if your fetal fibronectin test is negative, then your risk of going into labor over the next 14 days is very low,
Hmm.
like less than 5%. So if it's positive, we're all a little confused. Like, I don't know, what does that mean? Does it mean that there was recent intercourse or there's some spotting, and sometimes even really heavy discharge can make it, falsely positive. So the false positive rate of this test is pretty high, and it's really ambiguous about, what you do about it. But if I have a patient that does have a positive fetal fibronectin test, I like to err on the side of caution. So usually I'm going to admit that person to observation. We can talk about whether or not they would like to receive antenatal steroids, which is a steroid injection that mom gets that helps the baby's brain and lungs and gut mature. And so that in the event that the baby does indeed deliver, then that baby will act older than its age and be a little bit more mature and able to survive, have a better survival rate. So that's an option that can be given. And then I think I also mentioned the magnesium drip that is used to help the baby's brain maturity and protect their nervous system. So those are two things that I do if I feel like delivery might be imminent. So I try to make sure that we try to buy some time to get those things on board if we know this baby is actually coming. But as I said, a positive fetal fibronectin test can mean many things. Oftentimes, I will just admit to observation for 24 hours, and then we observe for contractions. We will give steroids if the mom would like to have that. And then many times the service is not opening, even though that mom may be contracting. And so we can, safely let them go home after a day or so. Like Dr. J shared, many folks with preterm contractions are going to go on to have a normal term baby. So, while it is scary, it's not, the end of the story, so to speak.
Right. Now, that begs a question, and I'm going to ask you both in your experience. You said that you give the mom the choice or the option of whether she wants the antenatal steroids. In your experience, first, how often do you have a patient refuse? Are there patients who say, no, I don't want it? Dr. J?
I'm sure there are, but in my experience, after you explain to a mom what the benefits are, I haven't had any patients that didn't want it at this point. In my clinical, I can't remember having a patient not wanting that. I had
Okay.
patients that didn't want other things, but that specifically, anything to help their baby, when you say this could help the lungs mature in case you deliver, most of them, that I spoke to definitely wanted it.
Dr. Joy?
I have experienced one or two people that just did not want, they didn't want antenatal steroids. And there is a specific population that I will say should not get antenatal steroids, and that is those folks who are over 32 weeks who have diabetes.
Yeah.
So if you have gestational diabetes and you are going and moving into that late preterm group, you do not want to get steroids because that actually increases your blood sugars exponentially for about 72 hours. And we know that uncontrolled blood sugars are an independent risk factor for stillbirth. So we don't want to set off a cascade of problems by giving those antenatal steroids. So generally, my patients that are above 32 weeks, I don't opt to give them antenatal steroids. If they have diabetes, I should say. But you can receive antenatal steroids up until 36 weeks of pregnancy if you're non-diabetic.
Thank you. You guys, if you've got questions, feel free to drop them in the chat and we'll I'll make sure we cover them at the time of that it pops in your head because I know I'm attention deficit, so I got to ask when it's there. So you've helped us understand the signals. Can we talk a little bit about what drives preterm labor? We know that there are times where it's not identifiable per se, right? But can we talk a little bit about, for example, for Dr. J, um, what are the most common medical causes of premature birth? I know we've touched on it a little bit, but we're going to ask the question specifically. Dr. Joy?
That is a very loaded question, I say. It's so multifactorial. From my lens, as a Black woman who takes care of mostly Black women, I think we really have to consider um, the the stress aspects that impact our community a little bit differently, that it kind of hits a little differently in our community. When we are stressed, our body makes a hormone called cortisol or a stress hormone. That hormone in sustained high levels in our bodies actually is the sort of the source of what we call weathering. Weathering is a term that has been coined now for about a decade or so, maybe longer. And it basically talks about the impact of stressors like systemic and institutionalized racism and how they actually affect the body. So even though we like to say black don't crack, internally, we are cracking. We have, blood vessels. We might be a 25-year-old woman, but we might have blood vessels and vasculature inside our body that is aged to that of a 50-year-old. And so one of the reasons that we see, I think, a lot of preterm birth is not only the systemic and institutional issues that we're facing, like not having the right access to healthcare, not being able to feel safe at any point at any time. There was a very interesting study that was done on Black folks with hypertension compared to white folks with hypertension. And they found that during the workday, when people were commuting and out doing all these things, that our blood pressures were pretty equal in both populations. But what they found that was very interesting in this study was that when they went home, our white counterparts, they seem to level out. Their blood pressures got more closer to normal, whereas Black folks continue to have this elevation. So it's almost as if we just never turn off the stress. So I think that that's very important to note. When we have high levels of cortisol all the time, it dysregulates the communication, the hormone communication between the brain and the womb. And it actually creates almost like a hostile environment for this baby. And so then it's like, oh, we got to get out of here. Let's start contracting so we can open this cervix and get out.
Get out.
So it is a very interesting dynamic, and I mean, the research is fascinating as it's unfolding, because it makes a lot of sense. Things that we've kind of known, and we tell people, "Well, don't stress, or, sit down." But how many folks in our community can afford to take 20 weeks off of work?
Mhm.
There's so many factors, just numerous factors, but I think that that's the underlying cause is the amount of stress and the epigenetics, like what we inherit from our ancestors who have faced all of these things, these tragedies, and have been resilient and survived. But that doesn't mean that our issues aren't still in our tissues.
Wow. It's a
I
powerful-
totally agree with 100% with everything you said. I tell my patients that every pregnancy doesn't take place in the clinical setting. It takes place in the context of a woman's life and her sleep and her work and her stress, her rest, her relationships, all of those things, the everyday factors, that's what matters also. And stress isn't simply about what's happening on a hard day. It's kind of how the body responds on those days. But like you said, it's stacked on top of each other. It's one stressor on top of the other. And I had a patient tell me, I'm carrying a black baby boy. Like she was so stressed after she found out the sex of her baby because of something that happened on the news. And she really, it was like we were going to send her almost to a therapist. She got that upset because of something that happened, and she said, "I'm carrying a black boy, and this is what I'm bringing my child into." So all of these things really can have an impact, and
Mhm.
a lot of times also labor can begin because of other factors that influences things. It could be how the body responds to, say, an infection or the stress, like you said, and or it could be related to the baby's needs. Sometimes, like you said, the baby wants to get out, so the baby's growth or well-being, can signal the body also to prepare to birth sooner. And life circumstances can make a big part of that. We have a lot of patients that have mental health issues that are in domestic violence situations. I mean, there are so many, um, things going on. Like you said, people can't take off from work to rest, and so it unfolds differently for every person. And so many families experience one or more of the influences. If it was just one thing, sometimes that would be okay. But when you have so many different things that can unfold, and many of course women go on to have healthy full-term babies. So the goal isn't to assign blame if someone goes into early labor or delivers early. I've heard moms feel bad that they had a premature baby. It's not about putting blame anywhere. It's the influences, the environmental influences, and the risk factors. I'd rather call them influencing factors than risk factors, because that sounds like we're blaming the woman for delivery, and it's not anything that we can put blame on. So we just have to do a lot of education, and the providers, all of us have to work together and stay observant. And the big thing, like Dr. Joy said, is the communication between the patient, the expected parents, the family, and the provider. Because if they feel comfortable talking to you, if they don't feel like they're bothering you to pick up the phone and call you or to get in touch with you when something's going on, that's so much of the problem now. Is a lot of people don't ask questions because they don't have that relationship or they don't want to bother their provider. But when you do a lot of communication, you ensure that care happens quickly and compassionately when they need to slow or prevent preterm labor, or at least get in touch with us to see what's going on with them.
Something that the two of you have described might explain a perplexing question that I've often harbored. When I see the data that says a Black woman with an advanced degree tends
Mhm.
to have a higher rate of preterm birth. Is that right?
Uh, Maternal mortality, everything really, but morbidity,
Maternal
everything.
mortality. So I want you to consider what it means to be one of the first, the few, and the only.
Mhm.
Okay. And those of us who might really, really try to do everything that our parents and grandparents told us, right? We
Mhm.
want to get the education, we want to get the credentials, we want to get the job, we want to get the house. So maybe we might delay our childbearing until we've accomplished those things.
Mm.
And then, you think about the stress that it takes to do those things
Mhm.
in our current climate. Those These are parents that have had probably high cortisol most of their lives, right? To
Mhm.
make sure that you are showing up in a way that is going to help you be successful, to police how you wear your hair, how you dress, how you speak, what you eat. I mean, there's so much that goes into that whole, and we're the most educated demographic in the country.
Mhm.
But how often, for all of those in the audience who are professional people of childbearing potential, how often have you been able to really walk into rooms in your profession as your authentic self? Think about that. We're
Mhm.
always under, some form of stress. And it's not that we're biting our nails and pulling out our hair, but there's always this expectation that sometimes we're, concerned about whether or not we meet it. So I think that that's a real thing. And not only that, but it it has to do with the systemic racism that's built into our system as well. Because regardless of all of the things that we've done to attain credibility in our society, we still aren't valued many times. We aren't listened to many times. We're dismissed more often. And so
Mhm.
all of those things play a role. And another thing that you mentioned, Dr. J, that I wanted to circle back to was mental health,
Mhm.
because we tend to be more likely to experience a mental health disorder during or after pregnancy, but the least likely group of people to be treated. So when we walk around with depression, anxiety, bipolar disorder, OCD, all of these mood and anxiety disorders increase our risk for preterm birth, low birth weight,
Mhm.
preeclampsia, and
Mhm.
diabetes.
And postpartum
Mm.
So,
depression.
yeah, I mean it's a really big deal, and we know that 1 out of 3 Black birthing people will experience a mood disorder.
Wow.
But we're less likely to be treated, to be diagnosed and treated. And some of it has to do with us, right? We have this I'm the strong Black woman, trope that we need to get get away from. But then because we have that trope, now a lot of people have a bias like, well, I don't have to ask her about her mental health. I shouldn't have to survey her. She's, a strong Black woman.
Mhm.
And so, we often may not feel comfortable talking about that. We may not feel comfortable seeking help or starting medications because that's not something that we have done in our culturally in our communities. But there are other appropriate interventions that could be through your faith community, through your family, your aunties. There are ways that we can intervene that don't necessarily have to be within the mental health system, but it is vitally important to get that mental health in order.
Yeah, yeah.
Oh, did you read my paper? That was my next question.
Really? Oh, okay.
My next question was
I
going to be,
promise
what
I
are some
do.
habits that make the biggest difference? We talked about stress and how that affects our blood pressure and that, the present pregnancy doesn't happen in isolation. So my next question was, what makes the biggest difference? What are some habits that will make the biggest difference? So one of the things you said is finding that support network or finding those. So that you started the conversation. We're going to let you finish your list. I know because one of the things that we did not cover about Dr. Joy is that she is an absolute brilliant advocate for maternal mental health. She is a certified one of few OBs in the country, world, whatever, who is a perinatal mental health counselor. So she fully understands the mental health component. So, and I know Dr. J has in her book. I'm going to do a pitch in her book. She addresses this as well. So let's talk a little bit about. I think if you'll bear with me, we've landed on something that is a driving, not driving force, but is a contributor, right, to preterm birth. What are some things? So, talking very briefly, seeking mental health, recognizing that I'm going to stop. We're recognizing what are the things that we should do.
I think one thing that we need to look at, and again, is pregnancy doesn't pause the rest of your life. People, you're pregnant, but I tell people that when you're pregnant, everything else that was happening is still happening. This is now on top of everything that else was happening. So it's something that we have to acknowledge. And like we talked about stress, long work hours, the demands from family and work, and even the way that we rest and eat, all of these things affect the body's rhythm. So um, we need to know that it's a part, stress is a part of living, but we have to start to learn how to manage some of that stress with rest and hydration and prayer and mindfulness and support systems. And that, again, the aunties, the family, the clergy, whatever it is that can get your stress level to come down some. And also mental health, therapists, psychiatrists, whatever you need. I say you can pray and you can still see a therapist. That works really good together
Mhm.
because in our communities, we know that often people say, go pray about it. That's wonderful. I'm a Christian and I can pray up a storm, but I tell you, if I need to speak to a therapist, I can pray and speak to a therapist. So that's the good thing with that. And the other thing that Dr. Dre mentioned that was so good is that for healthcare providers, it's our role to see the whole person. Like tonight, I'm loving her. She just is talking about what's happening. But if you think about the reality, a lot of our clients walk into an office, they have 20 minutes to get in, out. Somebody's typing and asking them questions and didn't even look at them. So how much are they looking at this person as a in a holistic manner where they're saying, what's going on in your life? Sometimes that's the question we have to ask. Sometimes it's not about the baby's heartbeat. I can hear that, but it's about what's going on with you. You look sad today. What's happening. We have to really look at the whole person, not just the pregnancy, because it's all together. It's not, you can't separate that. And then when they come to see us, we have to have a calm, safe space where we actually can help them lower the stress level. Some of our clients walk into a medical facility, their stress level goes through the roof. The way they're addressed at the desk, the way they're treated, where they feel afraid to ask questions, and they leave just the way they came in without any answers for their questions. So we have to make sure that when they come to us, that we're giving them compassion, that they know that we're seeing them. I had a patient that came in my office, and the other thing is until they trust us, they're not going to tell us anything either. That's the other thing. So you have to build that trust. And I had a patient, she came probably 3 or 4 times. And this next time that she came, I was just looking at her and I said, what's going on with you? I said, you don't look right today. Something's going on. And she was like, no, I'm fine. And I was like, no, you don't look fine to me today. I said, and I just did her exam and everything. But before she left, I questioned her again. And then she explained to me that she was in a domestic violence situation. But that was like the fourth visit. She didn't tell me that from the beginning. So think about where her stress levels have been the whole pregnancy. And we were able to get her plugged in and get her some help. But, you know, we have to see our patients. I think that's one of the biggest problems that in the maternal health realm is with like Dr. Joy said, we're not seen, believed, heard. Those things are so important. So I think the more providers we can get that look like us And now, we have to really be out here and talk to the youth and talk to the young women and the young men about nursing, about medicine, to get them into this field so that there's more of us. Because I think that's a big part of our answer to improve maternal health in this country.
Thank you,
I
Dr. J.
totally agree. When you come into my office, we I have been so intentional about the space and
Mhm.
about who is at the front desk and what it looks like when you come in. And then when you come to the back, we don't turn our lights on, our overhead lights. We have little sconces and we have a skylight that shines down from the
Right.
center of the back office. And we have, nice picture, art that just basically shows women doing work and families and exercising and spending time with each other. So we wanted women in all of their different states. We
Mhm.
have, folks with disabilities, folks who are LGBTQ, like on our walls, so that we want everybody. And when you come back headed to the nurses station, on our nurses station, it says, "Love lives here."
Mm.
And we meet every month. And one of the things that I always say in our staff meeting is, regardless of what's going on outside of these walls, when people come in here, they need to know that they're safe and that they're loved.
Oh, I love that.
So, because we know that people are catching hell outside of our doors. And one of the things in the last year that happened that was so profound to me was that I too had a patient who was suffering in a intimate partner violence situation, and she was beaten brutally by her significant other and had to have stitches in her forehead. And she left the ER, and the first place she came was to my office, and she still made
Mm.
it to her 8 a.m. appointment. And I said, "Well, what?" I said, "You could have called us and told us that were in the ER all night, and we could have gotten you a different schedule." And she said, "No, I wanted to come here."
She felt safe there.
Yeah, she said, "I wanted to come here." And we were able to find her alternate housing and get her. But I mean, that I know that we're so busy and we're running in and out of exam rooms and trying to see people in 15 or 20 minutes, but that is what we have to get back to, is when we actually spent time looking at the patient. My favorite technology right now is my AI that writes my notes for me so that I can sit there and have eyes on the patient, and we have the best conversations, and the AI doesn't pick up, "Oh, I like your shoes, girl." It just does the medical stuff, but it allows me so much more time because I'm not worried about getting behind on writing notes. I
Mhm.
can just talk to my patients, and then when I'm done, the note is written for me. That's my absolute number one favorite tool
Awesome.
because I spend so much more time in the room with my
Mhm.
patients now.
Engaged in that human interaction.
Hmm.
Wow. Something that you both said reminded me. We did a workshop a few months ago now. This year's gone by fast. With intimate partner violence expert team from one of Chicago, but it's in our on our YouTube channel. But one of the things that they said in their experience and their expert experience is that intimate partner violence actually escalates during the
It does,
pregnancy,
yeah.
as
It does.
opposed to what I think logically I would have thought would be the reverse. And so, huh. And then something came to mind, and I apologize from my deviation from our primary subject, but something that came to mind when we were talking about mental health. Dr. Joy, you have shared in other contexts about how Black women tend to present differently when we have a mental health experience, if that's the right word. And you shared about one of your patients, the one that was angry, that
Hmm.
that everybody else just thought she was mean. Can you share, because sometimes we have practitioners in our audience. I don't know how many are today. No one has said that they're preemie parents. So I'm going to assume that a significant number of our audience members, well, and some of them have said too, that they're birth workers. But I think that was a really critical learning. Would you share that snippet with our group?
This was a patient that had recently delivered, and she was just off the chain. Like, she was going off on people and, cussing out the front desk and, sending these angry messages through the patient portal. And I was just like,
Mm,
because we've known, she's been our patient for years. So when she came in, I said, what is going on with you? Because I said I had to sit her down because she was just really wreaking havoc throughout the entire practice and say, what's going on? This is not how you usually operate. And she said, I am so irritable all the time. And she told me how she was on the verge of being fired from her job because she just was snapping at everyone. She wasn't able to get along with her coworkers. And so I immediately said, we need, to screen for postpartum depression, which we screen all the time here. But I said, I would like to know how you've been feeling. So we went over the questions, and her postpartum depression scale was actually quite high. It was over 20. And so I said, sometimes you can have rage or irritability. It's not necessarily always just tearfulness or sadness or not getting out of bed in the morning, but sometimes people can just be very, very agitated. And so we were able to get her treated, and she came back a few weeks later, and she was just like her countenance was just completely different. She was smiling, she was happy, and she said, thank you so much for sticking with me because she said, any other doctor probably would have kicked me out of their practice after I did all the things I did to the staff. And I said, well, I knew something was wrong with you. And once we had a chance to figure that out, we were able to get her some help. And she was able to go back to work, and she's working on a parenting plan with the father of the child. So it was just so much going on in her life. And I think she had alienated a lot of her support because she was just so angry. And
mm,
so I think that's important to note is that sometimes people will present with behaviors
Mhm.
that are, more of a symptom of a larger problem.
mm, mm.
And that's why our support network, our families, our churches, our communities need to be able to be present and intervene and just say, hey, what's going on with you? How can we help you get back? My husband says stuff to me because I can get a little feisty sometimes, and he'll say this, he'll say, you know, you're not really presenting as your best self right now. How can I help you get back there?
Mm.
So it's like, what can you say to that? But dog, I guess I better get my act together, right? So,
I can't imagine you ever being feisty. You always have such a beautiful smile. But maybe we reserve that for Mr. Leaks and not the rest of the world. But I think something that you've highlighted, Dr. Joy and Dr. Day through this conversation is the importance of good communication, right? And so thank you for deviating a little for those of us that wanted to talk about something slightly different. So circling back now to our premature discussion or prematurity. Communication under that auspice, what questions should we ask um, if we are faced with this situation? What are some questions that we need a pen and paper? What are we going to jot down, and what should we ask if we are? What should we ask?
Okay. I'd love to jump on that one.
Okay.
When we talk about human connection and communication, which we started to kind of elaborate a little bit on, I think I'm talking at this point to the healthcare professionals that are in our audience. And I used to have midwifery students and medical students and new nurses on our unit. And I used to always tell them that for us, it's just a normal day. We're coming to work. This is a normal thing for us, and we do it every day. But for that patient, this may be the hardest day of their life. And it was just another day until it wasn't. That morning, when someone comes in and all of a sudden they're in preterm labor or they're getting ready to have a premature baby, it was just a normal morning. They woke up and now they ended up on our unit, in our office, in our hospital. And for that mother, that birthing person, that family member, it's the moment that everything could change. And so their fear, their tears, their silence, their anger, whatever comes out, we have to know that they're dealing with so much and it's real and it's valid. And how we show up that moment matters more than anything that we ever document in a medical chart. our tone, our presence with them, our willingness to explain and to sit with them. And that's what they're going to remember long after they're gone home, long after they deliver, they have a baby in NICU. They're going to remember how they were received, how they were treated. I'm sure a lot of people saw that video this week on the social media. Just every time I think about it, I just cringe. Okay, I tell people compassion doesn't cost a penny, and it can create
Mhm.
such trust in such a short time. It wasn't. It was just another day until it wasn't. And for us, like we said, everything can feel very routine for us. We know the processes, we understand the patterns, but for that family, that moment changes everything. They're confused, they're anxious, and that's all normal. And that's why our approach matters so deeply. Like it's what we do, it's how we speak to them, it's how we listen. Do we reassure them? Every conversation is a teaching moment, and I think that it's when we plan ahead. And when a patient comes in and we start planning ahead, okay, we see this person's coming in preterm labor. I'm a midwife, so that's a high risk patient to me. I'm basically handing this patient off to a OBGYN. I can co-manage with them, but there is a doctor that has taken over the care of these patients because preterm labor, preterm delivery is high risk. But we need to plan as a team, and we get people involved. Like as soon as that patient is deemed she's going to deliver, we should get the neonatologist there to talk to the family. I mean, we want them to have as much information to meet the people that are going to be in their care. We want to make sure they meet the nurses from the NICU, they meet the neonatologist if that's possible. And if not, we can at least explain these are the people that are going to be helping your baby. And so we want the families not to feel like they're alone in this. They're surrounded by a team that's already steps ahead of them, that's thinking how we can best take care of them as a unit. And life happens, as the kids say, life be life. But you know what? Our job is to bring calm in the middle of chaos. And so it's how we communicate, how we present with them. We have to be that steady presence that says, we got you. Even if things are not going according to your plan, we got you. We're here with you, and listening and believing. And collaboration is not about just medical, it's about emotional safety. Because these patients, they are just coming into a environment, they're walking in, they don't know who they're going to walk into that hospital and meet. So when they walk in, they have to feel safe. And so that, I think that's one of the biggest things that sometimes is failing in a lot of the practices. That's why I love the way you say your office is and the way you have meetings with your staff, Dr. Joy, because there's so many places we know don't have those kind of meetings. Patients just, it's about numbers and, timing. You have 20 minutes in and out, you're behind, you have patients waiting. But that patient has to feel heard when they come in. They have to feel like they were safe and that they felt comfortable, talking to you. So we have to, patients have to feel like they can ask questions. And if something doesn't feel right, they feel they need to learn how to speak up. And if we shut them down, they'll stop asking questions. And that's the scary part, when they stop talking to us, because that's when the preterm labor starts and we don't hear about it until they walk in ready to deliver. So we have to make sure that we're making room, we're slowing down and we're making room for questions. And um, part of that care is listening and explaining things clearly in a way that they can understand what we're talking about, and reminding families that they're not a visitor in this process. They are the patient. They're at the center. They're not there as a visitor. We're there to say, it's your body, it's your pregnancy. We're here to help you, but they should be at the center of that care. And we should never make them feel like we're making all the decisions and we're leaving them out. So that communication is like 100%.
Very
Yeah.
much.
In terms of questions that you can ask or should ask, honestly, we should be screening for signs and symptoms of preterm labor, asking you questions like, are you having any bleeding or spotting, any abnormal vaginal discharge? Because I mean, we should make some vaginal discharge, that's normal.
Mhm.
But are you having any abnormal vaginal discharge has an odor or a strange color to it? Are you having leakage of fluids, like fluid that just kind of keeps coming or draining?
Mhm.
Have you been having any regular painful contractions? Like these are things that we probably should be asking at visits, but if you're not asked, it's okay to bring those things up. And I think it's also very fair to ask about, you know, if you're having these symptoms, like, do you think that I'm at risk for preterm birth? And how do we start to keep an eye on that so that we can rule that out or prepare for that if I am? And so most hospitals that offer maternity care services have what's called an OB-ED or OB triage. And so if you think that you're having these symptoms and say your doctor's office is closed or they can't see you on that same day, it's totally acceptable to go to your birthing facility, wherever you plan to deliver,
Mhm.
and to have some of these exams that we talked about. The fetal fibronectin test or an amnisure test is another one that you can do to rule out that someone's water has broken. So there's lots of different questions that you should ask. You can also talk to your OB care team if you've had a history of preterm birth about the risk of a subsequent preterm birth. So, if you've had one preterm birth, you are at a higher risk for having another one. So sitting down and talking with your physician or midwife about, that entire birth story and what happened there and how can we think about prevention in this next pregnancy? So those are really great conversations to have. Um, in my office, we constantly screen for cervical lengths at that 20-week ultrasound. And the cervical length is just sort of an opportunity for us to look and make sure that we don't see a cervix that's getting short or opening when we're just doing our regular head to toe exam on the baby via ultrasound. And so that cervical length really needs to be greater than 2.8 centimeters. If it's not, that gives me an opportunity as a surgeon to intervene to actually place what's called a cerclage. A cerclage is basically a stitch that goes around the cervix. And I always talk to my patients like those bucket bags that have the little the
Bullshit.
little straps that the drawstring, you pull it and then you cinch it down. That's exactly what a cerclage is, but it's helping keep your baby in instead of your lipstick. So I put that around the cervix, and we have identified several people whose cervices were just sort of opening, and that's what we call cervical insufficiency, where the muscle is not strong enough to carry the weight of the pregnancy. So that is a big cause of preterm delivery. And those people may have zero pain at all. Their water may break, or they may start to feel intense pressure, and their second, trimester baby is coming. So there's so many things that can occur. And I do want to acknowledge, Marie, that there are some questions in the chat. I didn't know if you wanted us to um, address those. You're muted.
Perfect. Yes, I did see the one about magnesium sulfate. Can magnesium sulfate also work on preventing seizures for the mother, or is it just mostly protective for the baby?
It also works to prevent seizures in the mother. So let's say you are 28 weeks and you have to be induced for preeclampsia because the blood pressures are very high, or you're having some other problems with like your liver function or kidney function. And so the cure for preeclampsia is delivery. So even when it happens really early, sometimes we don't have a choice and we have to work, to get those steroids on board, to do the magnesium for a baby's brain protection, but also to help reduce the mom's risk of having seizure
Mm.
in that setting. But we don't really use there are a couple of different magnesium regimens. Let me just say that. And for prematurity, the regimen is a little bit different than what we might use for preeclampsia, but you can certainly combine those. So we might use a little bit higher dosing for baby's protection than we might for protecting mom from seizure. So, but you can certainly, it's going to give you benefit if you have preeclampsia and you're being induced early.
Mhm.
Yeah.
Thank you for that question. I did not realize that, Chloe. The next one was, have either of you found that women who've experienced multiple abortions have a higher risk for preterm birth?
No.
No,
Mm-mm.
no,
And
Chloe.
I guess, the thought behind that might be that cervical insufficiency issue because during abortion care, people or the physician, the surgeon dilates the cervix in order to be able to perform the abortion care. But there really has not been um, any documented association with folks who have had terminations of pregnancy and preterm birth. However, folks who have had cervical procedures like a LEAP or a cone biopsy, where a portion of the cervix is removed, those folks do have a higher risk of preterm birth. And they can also have a higher risk of that cervical insufficiency because a portion of the cervical muscle has been cut away.
Ah, thank you. Um, any other, let's see if there are any other questions. Do drop them in the chat or in the Q&A. I don't see any in the Q&A. Um, both of
Oh, I
you,
do see Chloe has asked, how does the AI technology work?
oh, I missed that one,
Um,
yes.
that technology goes through our electronic health record. And so what we do is we are logged into your chart and we can take a cell phone or a tablet in and it will record the conversation and it picks out all the things that are about related to your healthcare. Because we talk about a lot of stuff in my office, a lot of deep stuff. We talk jokes and funny things. And when I first got the AI, a hilarious story, a patient of mine had a labioplasty, and she was telling me a joke about her husband. They own a farm, and they had this great harvest. And so her husband said, "Well, I guess we can go get a labioplasty now." And so he said, "Well, Papa's gonna buy you a new vagina." And I was so nervous. I was like, oh my God, did the AI pick that up? So I told her, I was like, I gotta go and edit this note just in case the AI picked. So I was reading the note, and it didn't capture the jokes. It didn't capture, us talking about life things. It strictly records the medical stuff.
Hmm. That's interesting that it knows how to screen out the I like your shoes
Mhm.
and,
Right. It
that
knows
sort of
that. And
thing.
I just we were cracking up because we were both like reading the note and I was like, oh, it left it out. So it does really preferentially screen for the important things that need to be documented in your medical history.
Right. Brilliant. Um, I know we're close to time, so I want to make sure we leave enough room for the two of you. This was such a wonderfully rich conversation and wonderful learnings. Um, you're both fierce advocates for families. So thinking about this in the context of premature births or just your experiences overall, what are three things that you always tell your families um, to do going through their pregnancy? Uh,
One of
Dr.
one of
J.
my biggest takeaways with my families is that I want them to know that they are the center of care and to always feel comfortable speaking up and asking questions. I want them to know that if they feel that they're in the presence of someone who is not listening, or if they go in with a complaint and they're really not heard and they don't feel that their concerns are being addressed, if they're having pain and they're not being addressed, I want them to say things like, what else could it be? Those are the words I want them to use, just like that. If they go in and they're having right lower quadrant pain and they're told, oh, it's just gas, I want them to be able to feel comfortable saying, what else could it be? Because what I found is if they do that, then people start doing a differential diagnosis. And at a point, some testing might be done if they need testing. Because what we know is that, for instance, if a woman goes and they did a study quite a few years ago where They were looking at women that presented in the ER with right lower quadrant pain. And in women that were Caucasian, they were diagnosed with um, appendicitis quicker than the black women who was usually diagnosed with PID. And see, that is because they didn't do the extra testing. They didn't go the extra mile. These women ended up, a lot of them ended up with having the appendicitis, but that wasn't the first thought. So we need to feel comfortable saying, if it's not this, what else could it be? So that's the other thing, because I don't want people to go in and be dismissed without having adequate testing, adequate treatment, and adequate evaluation.
Yeah, absolutely. I think you bring up such a very important point. And I say this all the time, and it just, oh, it's like my pet peeve. Pregnant women get the worst care
Mhm.
out of anyone in the world. And it's because we get so focused on the baby that we often forget to take care of the mama. And the mama is vital for the baby. Like, baby, many times, these babies will not survive and thrive without their mothers. So we need to focus on that. I go to the Society for Maternal Fetal Medicine Critical OB Care course every year in Arizona. And there is a great one of the instructors is fantastic, well known physician, and she always says the same thing every single year. She says, think about what you would do to evaluate and diagnose that patient if they weren't pregnant.
They weren't
Then
pregnant.
do that. That's what
Exactly.
you should do.
Exactly.
Because like with the appendicitis thing, I had a patient a few months ago who came in with right lower quadrant pain. She was 36 weeks pregnant
Mhm.
and just was in terrible pain, but she wasn't having contractions. Cervix wasn't dilated, but she's writhing in pain. And she had talked to several, I came on call maybe a day or so after she had been there. And so I just went in to ask her, just kind of talk to her and see her. And she starts telling me this story about, she ate something and she got nauseated and she really just hasn't had an appetite and all this classic appendicitis, right? The story reads like appendicitis, but no one had done imaging on her, or they didn't do the right imaging. They got an ultrasound, which you can barely
Exactly.
see anything but the baby on ultrasound at 36 weeks. So I got a CT scan. And she did indeed
Mama.
have appendicitis.
Mhm.
So we ended up going in because we were going to have to deliver her to get to the appendix.
Yeah.
So we ended up going in, and the appendix had ruptured.
Mhm. Mhm.
So, this lady really could have
Good
become
night.
very sick
Yeah.
and died
Yeah.
because we just weren't, we weren't paying attention to all the other things. What else could it be? Like Dr. J
That's
says.
that's right.
We know it's not labor. What else could it be? We have to look for those things. You're getting bad headaches during pregnancy. Yeah, it could be hormones, but what else could
What
it
else
be?
could it be?
It could be a
Exactly.
clot in your head. It could be a mass. It could be increased pressure in your brain. Like there are so many other things, and I feel like it's often dismissed, and we don't go searching for things the way that we should. Are you feeling short of breath? Yeah, some people do feel short of breath as the baby gets up under the diaphragm, but
What else could it
let's just work that up. Like, let's make sure that you don't have asthma or,
be? A pulmonary embolus.
COPD or pulmonary embolus or heart problem. I mean, there's so many things out there. And so I think that we often miss the boat as healthcare professionals when we don't investigate.
Yeah.
Um, Gotta be investigative.
Yeah.
So what else could it be? And what else could it be?
Like we say, pregnancy doesn't happen in isolation. That's the whole point. That's the piece that's
Mhm.
missing so often. People
Mhm.
just look at the belly and don't look at the whole person to say, yeah, that's exactly
I agree.
part of the problem. Yeah. Wow.
Wow, such a learning. Someone said we want a shirt now. This is what else could it be? So you guys
Yes.
put it in your phones,
That was
make your notes when you go, and then have that as your follow-up question. What else could it
what
be?
else could it be?
Um, Dr. Joy, Dr. J, final thoughts before we go. Things that you want, anything that we've missed that you're like, oh, we've got to take this away.
The one thing that I want to say, I got a chance to give a talk recently at the Not on My Watch conference in Atlanta,
Oh, wow.
Mhm.
and I was tasked with speaking on preconception health.
Oh, yeah.
And I really believe I presented a holistic framework on planning for pregnancy. And I think that when we are intentional about pregnancy, it gives us so much more depth to be able to seek care early, to
Mhm.
know what condition our body is in before we conceive, to know what things we should be doing or not doing, avoiding or pursuing. It's a big deal. And I think that we can really help shape healthier pregnancies by being intentional with how we do our preconception health. And our health is centered around, I love the framework of the four pillars of health: what we eat, how we sleep, how we move, how active are we, and then our managing our stress. So getting those things together as much as possible. A huge reason for preterm birth is chronic medical conditions.
Mhm.
It's probably, I don't have the exact numbers, but it's probably on equal footing with preterm labor. Is that I'm being induced because I have an uncontrolled medical condition that makes it dangerous for me to stay pregnant. So, managing chronic conditions, getting that blood pressure under control, getting that diabetes under control, sleep apnea under control, if you need a CPAP, preconception health allows you to address as much as you can address before you become pregnant so that you can create a better environment within the womb. And also, in that framework, I talk about relationships. I talk about finances. What happens if I have to sit home for, 10 or 12 weeks because I'm on bed rest to prevent preterm birth? Like, have I planned for that? Am I financially ready for that? Can I feed my family and pay my bills? There's a huge, am I with the person that I want to be with? Do I feel like I have a village and support in my community? Do I have a care provider that I feel comfortable with, that I would go and see for a pap smear, let alone the most important time in my life when I'm, getting ready to bear my children? So those are all things that if we could sort of plan for on the front end, it will help alleviate a lot of those stressors we talked about on the back end.
That
Excellent, excellent. Wow.
sounds like a workshop we may need to have for our audience.
Oh, Dr.
Mhm.
Joy, did you read my book? Because you just told me my whole chapter. I have a whole thing in the appendix about preconception health.
Well, I mean, it is so vital. It is so vital. And,
It is.
and, just getting yourself to a healthier state. If you need to get on a blood pressure med, if you need to get your sugars under control, if you need to shed a few pounds, that's another, a huge contributor to preeclampsia and diabetes in pregnancy is living with obesity or overweight. So those are things that we actually do have some control over. We didn't build this system, and it certainly was not built for us.
Of course.
But the things that we can prepare for and control, we really should take advantage of that.
Yeah.
Ah, thank you both for your clarity, your compassion, the way that you've just educated us on so many things. Yes, to those in the audience who are asking, we will have the recording. We will also share contact information for both Dr. J and Dr. Joy. If you're in LaGrange, Georgia, obviously we found that the best OB ever. I think if I was pre-conceiving, I'd make a move to LaGrange so I could make sure I delivered with her. And I only say that in half jest. We made sure that my daughter had one of the best docs we could find in New York. So, and it makes a difference, right? And so the preconception, one element of that is interviewing your doctor. And if he or she doesn't sit down and talk to you like these two brilliant women, keep looking. So thank you for spending time with us, both of you. Premature birth touches far too many families, and early recognition, the confident communication that you all have outlined truly can make a difference in the outcomes. Tomorrow, we are having another workshop. Rarely do we have two back to back, but we have At 7:30 Eastern, Strength in the Struggle, Lessons from a Complex Birth Journey. We're talking about premature birth. Tomorrow you'll get to meet Lauren, who is a brilliant attorney who gave birth to twins at 34 weeks. Her delivery quickly shifted from um, to a critical element where she was in a coma, multiple surgeries. But two things. One, very happy ending. So don't come thinking we're going to scare you to death. Her twins are thriving, but her story does hold some important lessons for families. And then joining Lauren will be Danielle Clayton, who is a former preemie herself, and is now a brilliant attorney in New York. We thought it was wonderful to see how there are happy endings, and Danielle is just like, we often, like I said, we see the tiny little baby and we don't know what happens. Well, Danielle is 26, 27 or so years later and just thriving. So thank you both for setting the stage. We hope to see all of you tomorrow. And then on Friday, we'll send the recording for both workshops. We will send links to contact our respective speakers today. And yeah, so Dr. J, thank you. Dr. Joy, as always, it's a joy. Learned so much, and we hope you get out of there before it's too terribly late and you can birth those babies and then go home to that
Go
wonderful
home and
man.
rest.
Yes.
Yes.
All right. Good night, everybody. Thank you so
Everyone,
much
good
for having
night.
me.
Good
Thank
night.
you. Bye-bye.